So the next case is Carlie Sigel. Carlie is also a GI pathologist, GI service, and she does cytology and GI. And Carlie always also has some kind of a twist to her cases. But anyway, her interest is pancreatobiliary cytology and correlation with histology and molecular. So there you go.
Thanks. So my one disclosure that's a little bit relevant is that last year Agios reimbursed me for train trip to Boston and back, but I don't have a current financial. We looked at some slides. All right, so this is a 23-year-old woman who presented with a chronic cough. That was her main presentation, but it turned out she'd also unintentionally lost 50 pounds, and she had another complaint she had was lower extremity swelling. And when they scanned her, they found a huge liver mass. This liver mass is hypervascular, heterogeneous, and there was a background of fatty liver. She also had a lung mass, which was pretty significant lung disease, which were consistent with metastasis. And that was why she was coughing and very short of breath. Her past medical history had no cancer in it. She had some cognitive delay. She was a never smoker. In her family history, she had a grandmother with ovarian cancer, and she was negative for chronic hepatitis, or hepatitis B and C. So they biopsied her liver first to try to figure out what's going on. And you'll notice if you reviewed the slides to preview before today that it didn't have any hepatocytes on it. The most of the liver core had a spindle cell population. And it has a kind of distinct architecture that's almost story-forming. It looks like there's this crisscrossing type pattern here. But the cells are very bland. There was a residual bile duct present that didn't look very concerning, and there were a few clusters of glandular cells kind of hanging off the edge of the biopsy, which you can't do much with, but they were a little bit atypical. Here's some more pictures of the biopsy. There's some dense collagen laid down. And more of these little, questionably, are they vascular? What is this? Are these just stromal cells? So a big IHC workup was done, which I'll show shortly. Here's more pictures of this pattern, which is all made of mesenchymal cells. Big panel. So in case anything carcinoma-like showed up on a deeper level, stands for carcinoma, SFT, GIST, low-grade fibromyxoid sarcoma, nerve sheath tumor, IMT, PEComa, fibromatosis, vascular. These are, oh, sorry, I meant to do that while I went through the list. I did animation. And all of these were negative. So the diagnosis that was arrived at was that like a low-grade mesenchymal neoplasm, because the staining profile argued against all of the entities we talked about in the last slide. But it was also noted that because there were lung lesions and the disease was pretty significant, that it's probably a good idea to see if doing a biopsy of the lung showed anything different. Now, very commonly at our institution, we do adequacy for touch preps. So adequacy using touch preps for core biopsies, and such was the case for this patient. And what's interesting, and these are read by two different individuals. The cytologist will get the touch prep. A cytologist will do telecytology to provide adequacy. And the touch prep had 3 areas of cells, which I didn't provide for you beforehand. And these are clearly glandular cells, and they're clearly a little bit abnormal. Clearly a little bit. They're abnormal, but not enough to really say much about. So one might say, this lady or this young woman had such a big tumor, and you just get 3 clusters of cells. Did we really call that adequate? Well, yes, someone called that adequate. So a little bit of learning from this specimen as we see what this turns out to be is that maybe more biopsies should have been done than just that one. But so there's rare clusters of atypical glandular cells. Again, there was a lot of communication with the clinicians about trying to firm up this diagnosis. So they biopsied her lung, and this is what it showed. So it's a very it's a cribriform architecture. It's glandular. There's a pink cytoplasm, and it's an adenocarcinoma. And so you think, well, what can we do? What would be the most efficient thing for us to figure this out, to include in our panel when she has a huge liver mass? And that's albumin mRNA-ish, which was clearly positive. So the diagnosis for the lung biopsy is metastatic cholangiocarcinoma compatible with an intrahepatic cholangiocarcinoma. So we'll talk a little bit about intrahepatic cholangiocarcinoma because it's a rare tumor. We'll talk about albumin-ish in the next few slides. So I've done a lot of work recently with intrahepatic cholangiocarcinomas, and I actually kind of knew how many of them had scars. It's around 20%. And then this is an example. So you can imagine how potentially, this is an untreated tumor, how potentially a huge tumor could have a huge area of scar and that you could only have a small amount of glands. And these glands have these small duct patterns have this anastomosing quality that it's possible that the residual stroma that was left over that looked like it was almost storiform and was probably just the residual framework for this tumor that had areas of death. So why did this 23-year-old get a huge cholangiocarcinoma? I don't know. Over half of patients don't have any risk factors for intrahepatic cholangiocarcinoma. And in the United States, it's a rare disease. But in other areas of the world, it's not a rare cancer. Those are the red areas. And so if you use, for example, some of the risk factors are chronic hepatitis, where U.S. population, the prevalence of chronic hepatitis is less than 2%. And in the Memorial Sloan Kettering population with intrahepatic cholangiocarcinoma, it's around 17%. But if you look at intrahepatic cholangiocarcinoma publications from these Eastern countries, their chronic hepatitis rates are more like 30 to 50 or 60%. So the risk factors vary worldwide, and it affects the incidence of cholangiocarcinoma. So cholangiocarcinomas arise from anywhere along the biliary tract. We call them intrahepatic when they're past the second order bile ducts, so they're past this branching point. Here they're called hilar or extrahepatic cholangiocarcinomas, and they're staged differently. More distal bile duct down here, but this is these smaller ducts is where we believe the intrahepatic cholangiocarcinomas come from. And if you think about the spectrum of bile ducts in the liver, you can understand why there's so much heterogeneity with this disease, because you have these interlobular bile ducts, which are small and cuboidal. Then you have septal and segmental bile ducts, which look more columnar, and then even more cytoplasm and more columnar appearance in these extrahepatic or hilar bile ducts. And so when we see the heterogeneity of architectural patterns in intrahepatic cholangiocarcinomas, we wonder, is it because they're coming from different progenitor cells? So in some cases, you can have these small ducts that anastomose with each other. Other tumors have very abrupt transitions with areas that look like ductal plate malformations or hamartomas. Others produce mucin in small to large quantities. So there's a lot of heterogeneity. But what's becoming a little more accepted is that you can kind of divide them into two groups within this heterogeneity, and that there's large duct patterns that look more like a pancreatobiliary tumor in that they have columnar cells. They are more likely to produce a lot of mucin, and they're more likely to infiltrate with large ducts with abundant stroma in between them. Yes, they can have more poorly differentiated areas with small, closely packed cells, but in the more well-differentiated areas, like large infiltrating ducts. So a lot of names have been given to these, like hilar, perihilar, or bile duct, which is kind of confusing because they don't have to arise at the hilum. Some of them present with this in a location of the liver that you'd expect it to be not arising from the hilum. So that's why we're kind of suggesting that we divide it between large duct and small duct patterns. This pattern makes up a very small number of our cases of resected intrahepatic cholangiocarcinomas at Memorial. It's only around 9%, whereas in other countries, it's like 40 to 50%. So you might ask why, and it's probably related to epidemiologic factors. Also, it can be related to the clinical diagnosis, because if you have a really large tumor at the hilum, it can be difficult to tell whether it's beyond the second order bile ducts. So maybe they're classifying some things that are really extrahepatic as intrahepatic clinically. So the small duct pattern, they resemble more closely in their well-differentiated form the interlobular bile ducts or canals of Herring. And terms that are used to describe these are peripheral, cholangiolar, or bile ductular. Peripheral also being problematic because these can arise at the hilum, because these small ducts can occur close to the hilum, where tumors can be large and involve the hilum. When I looked at whether it was important to subclassify them further beyond just small and large duct by looking at tumors that had a predominantly tubular or anastomosing pattern, it was very difficult to sort out that had any significance. But both the large duct and small duct have been shown to have different staining patterns, and I'm sure we'll learn more about the molecular differences, one of which is that the large duct are more likely to have KRAS mutations, but that's more in development. So histologically, these are distinct patterns, but right now they're not known to really influence survival, and they're not treated differently, partly because this is a rare tumor and it can be hard to show survival differences. But we have seen that, and it's pretty consistently seen, that the large duct has larger rates of perineural invasion, more mucin production, and that they don't have that hepatoid cytology that you can see sometimes in the small duct type. They also have a different interaction with the surrounding liver, and different appearances to their stroma that are associated with the tumors and the nodularity. So how useful is albumin mRNA-ish for showing that tumors, adenocarcinomas, are arising from the liver? Well, it depends upon who you ask and which laboratory is performing it, because if you look at the most recent large study, aside from the one that I did, they said it's 99% specific for intrahepatic cholangio, meaning it's stained every case they had of intrahepatic cholangiocarcinoma was positive for albumin, but their threshold, as was mine, was extremely low, like only 5% of tumor cells, and you call it positive. So you can imagine that can be kind of hard to use in practice, because not many people would have a lot of confidence in seeing such focal staining to define something as reliable. With us, it was more like 66% of the intrahepatic cholangiocarcinomas, but what was interesting is the large duct type are mostly negative. So the take-home point is that if the question is whether a metastatic tumor is arising from the liver and it's got mucin production and columnar morphology, it's a lot less likely to be positive for albumin, even if it truly did arise from this second order bile duct or above. So, but the small duct, it's more helpful. So just last week, we got the IMPACT results. This is well after I had decided and finished putting this together. But we got the IMPACT results back. And what's interesting about this case is that it has an IDH1 mutation in the hotspot R132C, as well as other mutations that are in the families that are commonly seen in intrahepatic cholangiocarcinomas, like chromatin remodeling genes. So what do we know about IDH1 and intrahepatic cholangiocarcinomas? It's that it's a recurrent hotspot mutation in 10 to 20% of intrahepatic cholangiocarcinomas, and that it's different from the IDH1 mutations in glioma, so you cannot detect it with the IHC that's used in gliomas. So if you try, you will fail. But so right now, you just detect it by molecular testing. And IDH1 has inconsistent impact on prognosis for the various tumors that it's seen commonly. And these two are ones I know less about, but my impression was that it was better and for a glioma, but worse or possibly no impact for AML. For intrahepatic cholangiocarcinoma, I think the jury's still out on that one because evidence is only more recently accumulating. It's either possibly better or has no impact. So why is IDH1 interesting? Well, IDH1 is interesting as a mutation because it creates a neoenzyme that leads to the accumulation of a very specific metabolite that's a result of I always forget what to call this, but it's the cycle for energy in your cell. Yes. So anyway, this builds up. So what leads you to wonder is if you're accumulating this product, is there going to be a morphologic change that's associated with it? So last year with our GI fellow, who's really great, he's not here, I'll praise him in his absence. He had the patience to look at this with me, and we looked at whether there were differences in the IDH1 mutant tumors versus non-IDH1 mutant tumors, in part because there is a small molecule inhibitor that can be used in IDH1 mutant tumors. And so what we found was that plump cuboidal and polygonal cytoplasm was present in a higher proportion of IDH1 mutants compared to non-mutants, and also that scar-type fibrosis was more common in them, which is interesting for this case because it does have plump cuboidal cytoplasm and it did have a big scar. So that's really tidy for my presentation here. So in summary, there's two distinct patterns of intrahepatic cholangiocarcinoma in the liver, large duct and small duct, and that albumin staining can be really helpful for establishing intrahepatic origin, but mainly for tumors with a small duct pattern. And also that these tumors can have a really big scar. And just stay tuned for more on morphology of IDH1 mutants in ICC. So. Questions?
That's a great presentation. So albumin has been such a well-known marker to have because we've been until this week that nothing the site of origin of cholangiocarcinomas. But I found it really puzzling. So in a normal liver, you see albumin is a marker of hepatocytes. So what are the normal cells that express it, and does it say anything about the cell, particular cell of origin or differentiation of these cholangiocarcinomas?
Okay, so for your question about which cells in the normal liver that it stains, yes, it stains the hepatocytes very strongly. Bile ducts inconsistently. So if you look at the non-tumor part of your slide, you'll see some of the small interlobular bile ducts will label with albumin and some of them won't. So I would say it's inconsistent for the normal labeling of the bile ducts. And as for which cells of origin, to my knowledge, I don't know of anyone using that to establish which cells it arises from. But yes, it's very helpful because it stains tumors of liver origin, hepatocellular, and of bile duct origin. Okay.
Anybody else? Okay, good. Great case.